Okay, let's unpack this. We're diving deep today into a really critical and often challenging area of clinical practice, severe traumatic injuries.
Right.
And specifically, we're focusing on the problem of tissue ischemia. Now, these aren't just simple injuries, are they?
No, not at all.
Yeah.
We're talking complex cases, things like crush injuries, compartment syndromes, those really severe open fractures,
Yeah.
the Gustilo class 3B and class 3C types,
Yeah.
burns, frostbite, and also those tricky situations like threatened flaps or
Yeah.
maybe replanted limbs.
And these conditions, they represent a huge burden, right? Not just for the patient, obviously, but for the whole healthcare system.
Absolutely. I mean, the National Trauma Organization reported just a staggering figure, $672 billion spent on trauma care way back in 2016.
Wow. And that number, it doesn't even fully capture everything, does it? Like lost employment or the deep psychological trauma involved?
Exactly. It's incomplete. And the tough reality is even with the best care, state-of-the-art orthopedic and other treatments,
Mm.
the complication rates in these severe orthopedically related traumatic ischemias,
Mm-hmm.
they're remarkably high, around 50% actually.
50%, even with optimal care.
Yeah. That tells you there's a real clinical need for, well, something more. For adjunctive therapies that can actually move the needle on these often less than optimal outcomes.
So that brings us to our mission today. We're taking a deep dive into acute traumatic ischemias
Right.
and exploring the potential role of hyperbaric oxygen, HBOO, in maybe mitigating some of these challenges.
And the source material we're drawing from, it's a pretty comprehensive selection, focusing specifically on HBO in these traumatic ischemias.
With a particular focus on crush injuries, it seems, but covering the others too.
That's right. Emphasis on crush, but it covers the related conditions as well. So we're going to, extract and really elaborate on the most important insights from this material for you, the specialist clinician who's navigating these difficult waters.
Okay, sounds good. So what's the roadmap for this deep dive? Where are we heading?
Okay, roadmap. We'll start by really unpacking the core pathophysiology. What actually unifies these different conditions?
Makes sense. Get the foundation right.
Exactly. Then we'll get into the, well, frankly, fascinating mechanisms by which hyperbaric oxygen actually intervenes, at a cellular and physiological level.
How it works.
How it works. Then we'll explore specific treatment protocols, the indications for these various traumatic ischemias. So crushing injuries, skeletal muscle compartment syndrome, thermal burns, cold injury.
Threatened flaps and grafts, too.
Yep, threatened flaps and grafts, threatened amputations, and threatened reimplantations. We'll cover those specific scenarios.
Okay.
Then, importantly, we'll critically examine the evidence, what actually supports these uses.
Always crucial.
Absolutely. And discuss the significant challenges and dilemmas in integrating HBO into practice today, because it's not always straightforward.
Right. The real world stuff.
Mm-hmm. And finally, we'll look at a rationale-based approach for sort of justifying its use when it seems appropriate.
Excellent. The goal here seems really clear then. Provide you, the listener, with a detailed, evidence-informed understanding to, well, better manage these really challenging patient presentations.
That's the aim.
Okay, let's get started.
All right, picking up right where we left off with that overview, we're transitioning now into the detailed exploration, starting with those fundamental concepts from the source material's introduction.
Okay.
So when we talk about traumatic ischemias, we really are talking about a whole constellation of disorders.
Right, not just one thing.
Exactly. As you mentioned, this includes conditions ranging from crush injuries all the way to compartment syndromes and extending out to burns and frostbite, too.
A broad spectrum.
It is.
Hmm.
And they truly do share these underlying challenges. And as you highlighted with that cost data, they represent a significant burden on the healthcare system.
Oh, quite.
And what's crucial to understand right from the outset is that in those severe orthopedically related traumatic ischemias, particularly the Gustilo class 3B and class 3C open fractures, the complication rates are indeed 50% or higher.
Still staggering to hear that number.
It is, even with optimal state-of-the-art care. And this high rate, it really just underscores that clinical need for adjunctive therapies like hyperbaric oxygen, something beyond just the standard surgical and medical management.
Something to add to the toolbox.
Precisely. The source material then takes us into the core pathophysiology and links it directly to how hyperbaric oxygen actually intervenes.
And that primary unifying concept, the thing that ties these together, it's the combination of the trauma plus the ischemia, right?
That's it, exactly.
Yeah.
It's not just the initial injury itself, whether it's, blunt force, crushing, thermal energy. It's the subsequent reduction in blood flow and oxygenation to the tissues that follows. That often dictates the outcome. That interplay is absolutely central to understanding the problem we're facing here.
Got it. Trauma plus ischemia.
Yep. And this brings us nicely to the three distinct time periods or stages of wound healing.
Okay.
And understanding these stages is fundamental because they tell us when and maybe how often hyperbaric oxygen treatments might be most effective.
Right, the timing matters.
Immensely.
Yeah.
So first we have the inflammatory stage.
Okay, stage 1.
Stage 1. This stage kicks off immediately after the trauma occurs. Or in the case of frostbite, it's initiated during that really critical rewarming process.
That's right after the insult, basically.
Basically. Now, what's fascinating and really crucial about this phase is that the oxygen requirements for healing, they're actually at their absolute highest right during these initial hours and days.
Highest right at the start. That seems counterintuitive.
It does, doesn't it?
Yeah.
But the reason is oxygen is needed as the fuel, essentially, to mobilize and activate all those precursors that are essential for initiating healing.
Ah.
Think growth factors, cytokines, prostaglandins, leukocytes, they all depend on having sufficient oxygen tension to get going.
And it's needed for managing the bacterial load, too, you said, the bioburden.
Exactly. It's vital for managing the bioburden, essentially helping the body's own defenses control the bacteria in the injured tissue.
Okay, so it's the stage with the greatest demand for oxygen,
Mm-hmm.
but also, paradoxically, the stage where the tissues have the least available oxygen because of the trauma itself.
Precisely. It's a double whammy, as you said earlier.
Yeah.
And several factors conspire to create this state of reduced oxygen availability, this significant hypoxia.
What kind of factors?
Well, you have direct damage to the blood vessels, obviously.
Okay.
That leads to leakage extravasation of blood and fluid into the tissues, which causes swelling, edema.
Okay.
And this swelling, this edema, it can mechanically compress and just collapse the tiny microcirculation.
It squeezes the pipes shut.
Basically.
Yeah.
You also get sludging of cellular elements within those small vessels. Think red blood cells stacking up like coins in rouleau formation or white blood cells sticking to the vessel walls. That further impedes flow. Then systemically, hypotension is often present. And sometimes the high doses of vasopressors needed to maintain blood pressure can, paradoxically, compromise critical organ and tissue perfusion by causing widespread vasoconstriction.
So the treatment itself can sometimes worsen the local problem.
It can, unfortunately. You also get vasospasm right at the injury site, restricting blood flow, and the entry of all those inflammatory cytokines and other signaling molecules, sometimes called cluster designations, based on how they're identified on cells.
Mm-hmm.
They just exacerbate the whole inflammatory process and contribute to local tissue damage. And importantly, there's reperfusion injury.
Ah, the damage when blood flow returns?
Exactly. The damage that occurs when blood flow is partially restored to ischemic tissue, generating all those harmful free radicals.
Okay.
And the source points out, the greater the energy exchange from the initial trauma, so the more severe the impact or the burn, the more likely these harmful effects are going to occur. They compound the initial tissue damage and drastically exacerbate the local hypoxia.
And this must be why, according to the source, earlier HBO's initiation during this critical inflammatory stage is more likely to mitigate that nasty pathophysiology associated with the ischemia. You're hitting it when the tissues are screaming for oxygen but can't get it.
Exactly right. You're intervening right when the need is highest and the supply is lowest. And the explanation for HBO's profound benefit here, it's firmly rooted in physics and physiology. It's not magic.
Okay, how does it work then, fundamentally?
The key mechanism is that hyperbaric oxygen. By increasing the ambient pressure around the patient,
Right, in the chamber.
it dissolves a significantly larger amount of oxygen directly into the plasma.
Into the liquid part of the blood, not just carried by red cells.
Precisely. This is a really important point for understanding how it bypasses damaged circulation. Oxygen becomes much less dependent on hemoglobin bound within the red blood cells for transport. It's carried directly in the plasma, and it's available to diffuse out into the tissues, even when normal perfusion, via those tiny compressed capillaries, is impeded due to the swelling, the sludging, or the damage.
So it's like a different delivery route?
You can almost visualize it like oxygen being carried in the plasma like sugar dissolving in water. It bypasses the normal delivery trucks, the red blood cells that maybe can't get through the congested roads, the damaged microcirculation.
That's a great visual. Dissolved oxygen getting through where red cells can't.
Exactly.
Okay.
Okay, moving on then. The second stage is the repair stage.
Stage 2.
Stage 2. This phase typically begins to taper in about, say, 4 to 6 days after the inflammatory stage starts, and it continues actively for a couple of weeks.
Okay.
This is the real, the workhorse phase of wound healing, where the actual reconstruction and function restoration of the injured tissues occur.
Building things back up.
Right. Now, a crucial concept that persists here, and can even get worse,
Yeah.
is that self-perpetuating cycle of edema and ischemia-hypoxia.
That vicious cycle again.
That vicious cycle again. The source depicts this visually, almost like a feedback loop in Figure 1. Edema formation, which was initiated by the injury in the microcirculation, increases pressure.
Right.
Now, when this increased edema develops within a confined space, think about the tight muscle compartments in compartment syndrome, or just the dense soft tissue envelopes around a severe fracture. That pressure can mechanically compress and collapse the microcirculation even further. It drastically restricts blood flow and perfusion.
And then that restricted perfusion leads back to the cellular hypoxia.
Precisely. And cellular hypoxia results in the inability of cells to maintain their oxygen-dependent intracellular water and electrolyte balance.
So the cells themselves start to malfunction.
They do. This leads to intracellular swelling, which in turn creates more edema in the interstitial space, the space between the cells. And this increased edema then worsens the ischemia-hypoxia by further compressing the vessels. And so the cycle just perpetuates itself. Swelling causes hypoxia. Hypoxia causes cellular swelling, which causes more interstitial swelling, which causes more hypoxia.
It just keeps feeding itself.
It's a destructive loop. You can visualize it like one cell swelling up, right? It bumps into its neighbors, which also start swelling because they're hypoxic too.
Okay.
And together, they just squeeze and compress the tiny blood vessels running around them, further shutting off their own oxygen supply. It creates this local zone of spreading compromise.
Nasty cycle. So how does hyperbaric oxygen disrupt this in the repair stage?
It works powerfully to disrupt this destructive cycle through two primary mechanisms. First, and this one sounds a bit counterintuitive again,
Okay.
HBO causes systemic vasoconstriction of the pre-injury arteries and arterioles.
Yeah.
It actually reduces overall blood flow into the injured area by about 20%.
Wait, less blood flow? Isn't that
Yeah.
bad? We need blood flow, right?
You'd think so initially, but the source clearly explains why this helps in this specific context.
Ah, okay. I think I see where this is going. Even with that 20% reduction in flow. The second mechanism must be that vastly increased amount of dissolved oxygen in the plasma you mentioned earlier.
Exactly. You've got it. You have reduced bulk flow into the area, which helps limit further fluid leakage and edema.
Right.
But you have a massively increased oxygen carrying capacity per unit of that blood flow, delivered via plasma diffusion, which, again, can reach areas where red cells might not be getting through.
So less water coming in, but much more oxygen per drop.
That's a good way to put it. The combined effect of these mechanisms is profound. You're effectively reducing edema formation by slightly reducing blood flow and simultaneously lessening the collapse of the microcirculation by helping shrink cell swelling and interstitial fluid, while significantly increasing the amount of oxygen available to the tissues that are getting perfused. So with improved oxygen tensions now reaching the cells, their metabolic processes can maintain that intracellular fluid balance, thus interrupting this vicious edema, ischemia, hypoxia cycle that's driving the tissue damage.
It breaks the loop.
It breaks the loop.
Yeah.
Now, the predominant cell types that are really driving the activity and repair in this phase are fibroblasts, macrophages, and keratinocytes.
The key players in repair.
The key players. Fibroblasts are absolutely essential. They generate collagen, that structural protein that forms the fibrous tissue framework needed for wound closure.
The scaffolding.
The scaffolding, exactly.
Yeah.
And it provides a crucial matrix or framework to support angiogenesis, the formation of new blood vessels right at the wound margins.
Oh, okay.
Macrophages, which originate from monocytes and bone marrow-derived progenitor cells, they play a critical role in cleaning up. They phagocytose cellular debris, eat up dead tissue, and importantly, help to control the infection load in the wound.
The cleanup crew.
The cleanup crew, yeah. And then keratinocytes. These are the predominant cell type of the skin, originating from the basal layer of the epithelium. They're responsible for reestablishing skin integrity over the wound, including contributing to the successful take and integration of skin flaps and grafts.
Covering the surface.
Right. And crucially, like those other leukocytes and the key players back in the inflammatory phase, the function of these repair phase cells, the fibroblasts, the macrophages, the keratinocytes, it's highly dependent on adequate oxygen tensions in the tissues.
They need oxygen to work properly, too.
Absolutely. Hypoxia significantly impairs their ability to proliferate, to migrate where they need to go, and just to do their necessary work of rebuilding.
Okay.
And it's worth noting, just as a key point regarding the strength of the wound at this stage, by the end of this repair phase, the tensile strength of the healing tissue is still only about 10% of uninjured tissues.
Only 10%. So it's closed, but still quite fragile.
Exactly. It's functional for closure, but it's far from full strength at this point.
Okay, so connecting this back. The inflammatory stage, that immediate aftermath, has peak oxygen need but minimal supply due to the injury effects, vascular damage, sludging, edema starting.
Right.
HBO helps by getting dissolved oxygen into the plasma, bypassing the jammed red cell routes. Then, in the repair stage, that vicious edema-ischemia-hypoxia cycle really digs in.
Yeah, it takes hold.
And HBO disrupts that cycle by, 1, causing some vasoconstriction to reduce the fluid leakage, and 2, massively increasing tissue oxygenation via that dissolved O2 route. This helps cells normalize, stop swelling,
Right.
and supports the key workers. Fibroblasts building tissue, macrophages cleaning up, and keratinocytes closing the surface. It seems like it's really hitting the core physiological problems at each stage.
That's an excellent summary. It really captures the essence of how it works in those first two critical phases.
Okay.
That brings us then to the third stage, the remodeling stage.
Stage 3, the long haul.
The long haul, yeah. This phase typically begins about 2 weeks after the injury, and it's a much slower, longer process. It might continue for months, sometimes even up to a year, until the tissue reaches its final form and strength.
Okay. What happens here?
Well, in the remodeling stage, the scar tissue that formed during the repair phase gets reorganized and modified. Closed wounds gain their full tensile strength, ideally normalize in appearance, softening, becoming less red. In bone, strength aligns with the mechanical stresses placed upon it, following Wolff's law, as the bone is resorbed and rebuilt. You see the resolution of the erythema, the redness, and the resolution of the swelling that might have persisted into the repair phase.
So things maturing and strengthening.
Maturing, strengthening, normalizing. The predominant cells involved here are fibrocytes, which are sort of less active cousins of fibroblasts, but they continue to remodel the collagen. And importantly, in bone, you have osteoclasts.
Osteoclasts, the bone-resorbing cells.
That's them. And it's vital to highlight this. Osteoclasts, the cells responsible for resorbing old or damaged bone and initiating that bone remodeling cycle. They have a metabolic activity about 100 times greater than osteoblasts, the bone-building cells.
Wow, 100 times more active.
Yeah. This makes osteoclasts incredibly energy-dependent and therefore very oxygen-dependent.
So even in this later stage, maybe months down the line, oxygen is still crucial for these cellular functions, particularly for healthy bone healing and remodeling.
Absolutely. Persistent soft tissue injury or, scar tissue from the initial trauma or subsequent surgery can impair perfusion to the underlying bone. The blood supply might still be suboptimal.
Ah, okay.
This is why hyperoxygenation is relevant even here. HBO helps mitigate those potentially hypoxic environments. It aids bone remodeling, supports robust bone healing by fueling those osteoclasts to clear out compromised bone, and importantly, it assists the body in clearing out microscopic foci of infected bone that might remain even after surgical debridements.
So it helps clean up lingering infection too.
It does. It provides an oxygen-rich environment that supports the host's own defenses and helps remove compromised tissue. It makes it harder for anaerobic bacteria to thrive and easier for aerobic host defenses to work.
Makes sense.
Of course, the remodeling process for hard tissues like bone is inherently slow compared to soft tissue repair.
Right.
While tensile strengths might reach about 60% of normal by 6 weeks in soft tissue, full bone remodeling takes much, much longer.
Okay, so thinking about the remodeling stage, this is the maturation phase. Scar softens. Bone strengthens according to stress. Key players include those super oxygen-hungry osteoclasts in bone. And HBO Euro supports this phase by providing oxygen where perfusion might still be iffy, aiding bone healing and helping the body clear out lingering microscopic infection.
You've got it. Now let's discuss the second unifying finding that the source highlights as defining traumatic ischemias. This is the concept of the gradient of injury.
Okay, the gradient. What does that mean exactly?
The source visualizes this quite well, showing sort of a spectrum of tissue damage within a single injury. Imagine a cross-section with different zones.
Okay.
This concept basically means that within any given traumatic injury, there's a spectrum of damage. At one end of this gradient, you have tissues completely unaffected by the injury. They're healthy, well perfused,
Normal tissue.
normal tissue. At the other extreme end, you have tissues that are so severely injured or so deprived of oxygen that they are, frankly, irreparably damaged, non-viable, dead tissue.
Right.
Now, in between these two extremes, there's a range of injured tissue. Some might be mildly affected, some moderately compromised. But critically, there's a zone of tissue that is injured but still viable. It's struggling, it's compromised, but it can potentially be salvaged.
Ah, the zone of stasis sometimes, the tissue on the edge.
Exactly. That's the crucial zone where HBO primarily operates. It focuses its efforts on that middle ground, the injured but still viable tissues within this gradient.
Okay, so what are its roles there?
Precisely. Hyperbaric oxygen has two primary roles in addressing these injured but viable tissues within the gradient. First, as we've discussed quite a bit, it improves the environment for healing in this compromised tissue through its core mechanisms, increasing dissolved oxygen and reducing edema. It helps those struggling cells get the oxygen they desperately need to survive and start repairing.
Okay, supporting the viable but struggling tissue. What's the second role?
The second role is at the interface margins, right at the boundary between the injured but viable tissue and the, frankly, non-viable dead tissue.
A demarcation line.
Exactly.
Yeah.
HBO helps facilitate demarcation. It makes that line clear between what is truly dead and needs to be removed surgically and what can potentially still be salvaged.
Ah, that helps the surgeon.
Immensely. It aids surgical debridement by making the target clearer, and it also supports infection prevention in this really critical transition zone where dead tissue meets living tissue, which is often a hotspot for bacterial growth.
Okay, that makes a lot of sense.
And it's worth noting, of course, that every traumatic ischemia injury is unique. The amount and the location of each zone in that gradient varies tremendously from patient to patient, injury to injury.
Right.
And the clinical symptoms don't always precisely correlate with the underlying degree of damage either, which is why objective scoring systems are frequently used.
Like the Gustillo classification you mentioned.
Exactly, particularly the Gustillo open fracture classification system. It provides a standardized way to describe the severity of open fractures and, importantly, the associated soft tissue injury. It's the most frequently used system in extremity trauma.
So you need those objective tools to help assess the severity and guide decisions, especially when the clinical picture alone might be a bit misleading or subjective.
Precisely. You need that objective framework.
Okay, so that covers the underlying science, the pathophysiology, the stages, the gradient. Let's move now from the why to the how, the practical application. Hyperbaric oxygen protocols. How is HBO actually used for these specific conditions?
Right. The treatment protocols using HBO for traumatic ischemias, they're generally based on two key factors.
Okay.
First, the time interval from the injury to when the treatment is actually initiated.
Yeah.
And second, the resulting pathophysiology associated with that specific timing and stage of healing. The source references tables 1 and 2 for some detailed algorithms and scoring, which we'll get into.
Right, the timing again. Seems critical.
It is. Ideally, HBO should begin as close to the time of injury as possible.
Why ideally so early?
The rationale here links right back to that inflammatory stage we talked about. The goal is to address that immediate ischemia-hypoxia state and augment oxygen availability right during that critical phase of highest oxygen demand and lowest availability.
Getting it right when the fire starts.
Exactly. So if HBO initiation occurs during, say, the first 24 to 72 hours, the recommendation is typically for 3 or more treatments. The source emphasizes that this schedule, targeting that acute inflammatory phase, is particularly effective in promoting the survival of threatened flaps and injured deep soft tissues.
Okay, early and frequent initially. What if treatment is delayed, say, until the repair phase?
Right. If HBO is delayed until the injury has progressed into the repair phase, which is typically, 4 to 6 days after the initial insult, then the recommended schedule changes.
How so?
In that case, daily, or preferably twice daily, treatments are advised, and these should continue for about 14 days.
Okay, daily or BID for 2 weeks. What's the goal then?
These treatments are directed at optimizing the environment for those cellular players in the repair stage, supporting fibroblast function for collagen deposition, macrophage function for debris clearance and infection control, and keratinocyte function for reepithelialization.
Supporting the builders and cleaners.
Exactly. They support processes like angiogenesis, the formation of healthy granulation tissue, and importantly, the successful take of skin grafts and flaps by improving the oxygen gradient and helping reduce any residual edema.
Got it. And what about even later, if there are problems with bone healing or infection in the remodeling phase?
Good question. If bone healing delays or infection, specifically osteomyelitis, is present during or after the repair phase. This means the process has transitioned into, or is maybe stuck in, the remodeling phase, and is often complicated by persistent hypoxia affecting the bone.
So here you're specifically targeting those highly metabolically active osteoclast cells and trying to clear infection, like we discussed.
Exactly right. Osteoblasts and osteoclast cells are the key targets for HBOs in this scenario. If bone infection is present, or if fracture healing is delayed due to persistent ischemia-hypoxia impairing osteoclast function and host defenses, then HBO should be used during the remodeling stage. The rationale, as we discussed earlier, connects back to that high metabolic activity of osteoclasts and how hyperoxygenation helps mitigate that hypoxic environment that impairs perfusion to the bone.
Okay. And the benefits.
The benefits here include aiding bone remodeling, supporting robust bone healing by fueling osteoclasts to clear compromised bone, and facilitating the removal of those microscopic foci of infected bone, even after surgical debridements. It creates an environment hostile to anaerobic bacteria and supportive of aerobic host defenses.
Makes sense. And the treatment schedule for this. Since bone remodels slowly.
Exactly.
Yeah.
Since remodeling of hard tissues like bone is a slow process, the recommended treatment schedule for this specific indication is typically longer, 3 to 6 weeks of daily HBO treatments.
Okay, daily for 3 to 6 weeks for bone issues. Now, you mentioned decision-making, especially the tough ones like amputation versus salvage. The source mentioned a tool.
Yes, the wellness score. To help guide clinical decision-making, particularly in those severe traumatic ischemias where that difficult question of salvaging the limb versus amputation arises, the source presents the wellness score as a very useful tool.
Okay.
The source actually describes this as a primary amputation tool. It's designed to objectively assess the patient's overall health status, which, as you know, significantly impacts their ability to heal and withstand complications.
Right. It's not just the injury, it's the patient, too. How does it work?
The wellness score assesses the patient's host status using 5 objective criteria. Each is graded from 2 points, which is best, down to 0 points, which is worst.
Okay.
These scores are then summed up to generate a total score, ranging from 0, the worst possible host, up to 10, the best possible host.
Got it. What are the 5 criteria? Can you walk us through Table 1 verbally?
Sure. Table 1 lays them out. The 5 assessments are, first, activities of daily living. Assessed as full, meaning independent, that's 2 points. Some assistance needed is 1 point, or none, totally dependent, is 0 points.
Okay, ADLs.
Second, ambulation. Assessed as a community ambulator, walking independently outside, that's 2 points. Household ambulator only inside is 1 point. Or none, non-ambulatory, is 0 points. And the table notes you subtract a half point if aids like crutches or a walker are used.
Okay, ambulation with a note on aids.
Third, comorbidities. Assessed as no significant comorbidities, that's 2 points. Impaired health status due to comorbidities is 1 point. Or decompensated health status, meaning severe systemic illness, is 0 points. And it notes that neurological deficits are assessed separately as criterion 5.
Got it. Comorbidities, excluding neuro for now.
Fourth, inhibitors. This looks at factors known to impair healing. Things like smoking, collagen vascular diseases, or the use of immunosuppressors. Having none scores 2 points. Past use or a history scores 1 point, and current use scores 0 points.
Okay, smoking, immunosuppressants, etc.
And fifth, neurological deficits. Assessed as none, that's 2 points. Some or minor sensation imbalances scores 1 point. Or major cognitive impairment or motor paralysis scores 0 points.
Okay, the neuro component. So you add those up, 0 to 10. How does that stratify patients?
The source explains that summing these scores stratifies patients into categories. A score greater than 4 points indicates a healthy host.
Okay, 4 is healthy.
A score in the range of 3.5 to 7.5 points indicates an impaired patient.
3.5 to 7.5 is impaired.
And a score from 0 to 3 points indicates a decompensated patient, a severely compromised host.
0 to 3 is decompensated. Okay, so you use this score, which gives you an objective measure of how well the patient can heal and tolerate the stress.
Right.
And you pair it with the severity of the injury itself, using something like the Gustilo score.
Exactly. The wellness score, paired with the Gustilo open fracture grading system, which classifies the severity of the open fracture and associated soft tissue injury, particularly important for those risks. Class 3 injuries provides predictable outcomes regarding complications. And Table 2 presents these guidelines. It shows how integrating the wellness score with the Gustilo types can help guide decisions about when HBO should be used, versus when a primary lower limb amputation might actually be the more appropriate, maybe even safer path.
Okay, this sounds like a key table. Can you walk us through Table 2? It sounds like it summarizes the algorithm shown in Figure 2.
Absolutely. Let's walk through Table 2 verbally. It pairs the Gustilo classification with the patient's wellness score category: healthy, impaired, or decompensated. First, Gustilo Class 1 injuries. These have minimal soft tissue injury, usually just a small puncture wound less than 1 centimeter, often caused by the bone poking through from the inside out.
Okay, simple open fracture.
Pretty much. In healthy hosts, the outcomes are usually no different from a similar closed fracture. Complications are rare. The HBO indication here, yes, but only for a decompensated patient in this scenario, presumably to try and optimize any healing potential in a severely compromised host, even for a minor open fracture.
Okay, Class 1 only for decompensated. What about Class 2?
Gustilo Class 2 injuries. These involve a laceration greater than 1 centimeter, but still with minimal deep soft tissue damage and no significant flap formation or stripping of tissue off the bone.
A bit more soft tissue involvement.
Right. Outcomes in healthy hosts are generally similar to Class 1, low complication rates. The HBO indication here is yes for both impaired and decompensated patients, recognizing their reduced ability to handle even this moderate level of injury.
Okay, Class 2 for impaired and decompensated. Now the big ones, Class 3.
Right. Gustilo Class 3 injuries. These are the crush injuries, characterized by significant soft tissue damage. And they depend on the subtypes, A, B, and C. First, Class 3A. Here, there's still sufficient soft tissue coverage remaining to close the wound after surgical debridement, though it might require some local tissue rearrangement.
Okay, enough skin to close.
Basically, outcomes in healthy hosts show about a 10% complication rate, definitely higher than Class 1 or 2. The HBO indication here, yes, for healthy, impaired, and decompensated patients. This is where HBO starts to show potential benefit even in otherwise healthy hosts, because the injury itself is severe.
Got it. Class 3A, HBOs for everyone, now 3B.
Gustilo Class 3B. These involve extensive soft tissue loss that requires formal soft tissue reconstruction. We're talking local or free flaps, and your skin grafts needed just for coverage after debridement.
Major soft tissue defect.
Major defect. Outcomes in healthy hosts are grim, even with optimal surgery. They show a high incidence of complications, 50% or greater. Things like delayed healing, non-union of the fracture, infection like osteomyelitis, and ultimately amputation are common.
Wow, 50% plus complications even in healthy people for 3B HBO indication.
Yes, for healthy patients. Now, for impaired and decompensated patients, there's an asterisk in the table noting yes, no.
Yes, no. What does that mean?
Footnote 2 clarifies this critical point. It advises that consideration for primary amputation is based on the overall severity of the injury, especially Class 3B and 3C, paired with the patient's wellness score. It recognizes that attempting limb salvage of these severe injuries in compromised hosts may not be achievable, or the morbidity might outweigh the potential benefit.
So HBOs might be technically possible, but amputation might be the better overall choice for impaired decompensated patients with 3B injuries.
That's the implication. It's a tough decision point where the wellness score really helps inform the discussion.
Okay, and finally, Gustilo Class 3C.
Gustilo Class 3C. These are essentially Class 3B injuries, major soft tissue loss requiring flaps grafts that also involve major arterial damage requiring surgical repair, revascularization, just to restore perfusion to the limb.
The worst of the worst, basically. Soft tissue loss plus vascular injury.
Pretty much. Outcomes in healthy hosts require grafts for bone coverage and still face extremely high complication rates, often exceeding 50%, similar to 3B. The HBO's indication. Yes for healthy patients.
Yeah.
And again, for impaired and decompensated patients, there's that same asterisk with yes, no, strongly advising consideration of primary amputation based on severity, as per footnote 2. The probability of successful salvage in a compromised host with a 3C injury is very, very low.
Understood. High risk of failure and complications.
Exactly. The table notes just reiterate that Table 2 combines the wellness score and the Gustilo grading to add objectivity to this difficult decision-making process. Footnote 1 confirms the wellness score ranges we discussed for healthy, impaired, and decompensated. And footnote 2, as we've emphasized, highlights that critical point about considering primary amputation based on the severity of the injury, Gustilo type, paired with the patient's ability to heal and withstand complications, wellness score. This table, along with Figure 2, which visually represents it, provides a really clear algorithm for when HBO is indicated based on both injury severity and patient health status, particularly in those challenging Class 3 cases.
That is incredibly helpful for thinking through those really complex cases where you are genuinely weighing salvage against amputation. It provides a much more objective framework than just looking at the mangled tissue alone.
It does. It brings the whole patient picture into the equation.
All right, let's pause for a moment then, just to consolidate what we've covered on the protocols. This seems really important. We've learned that the timing of HBO's treatment is crucial. Ideally, you start early, in the inflammatory phase, the first 24-72 hours.
Right.
With a shorter, more frequent course, maybe 3 or more treatments, to maximize oxygen diffusion when tissues need it most and supply is lowest.
Correct.
If treatment gets delayed until the repair phase, say days 4 to 14, then it's daily or maybe twice daily for about 2 weeks. The goal there is supporting the cellular healing processes, angiogenesis, graft take, etc.
Precisely. Supporting the repair workers.
And then for bone healing delays or infection, which pushes you into the remodeling phase, after about 2 weeks, that requires a longer course, daily for maybe 3 to 6 weeks, to support those really oxygen-hungry osteoclasts and help host defenses clear infection.
You've summarized the timing and duration based on phase perfectly.
And critically, we now have this framework using the wellness score, assessing the patient's overall health, combined with the Gunstillo classification assessing the injury severity, as shown in Table 1 for the score and Table 2 and Figure 2 for the combined algorithm. This helps us objectively determine which patients, based on their overall health and the severity of their injury, are the best candidates for HBO. Or, importantly, when the odds of success are just so low, particularly in impaired or decompensated patients with Gunstillo 3B or 3C injuries, that primary amputation should be strongly considered.
Excellent summary. That really captures the key points regarding protocols and decision-making based on the source material.
Good. So now let's transition. We've used crush injuries as the main example, the prototype.
Okay.
But let's expand our focus beyond crush injuries to those other acute traumatic ischemias where hyperbaric oxygen might also play a crucial role, presumably because they share those similar underlying pathophysiological principles we discussed.
Exactly. The principles apply more broadly. So first, let's discuss skeletal muscle compartment syndrome, or SMCS.
Okay, compartment syndrome.
This problem is typically associated with either a closed fracture or maybe major blunt trauma to the soft tissues, crucially where the strong fascial envelope around the muscle compartments remains intact. It hasn't been surgically opened.
Right, the pressure builds up inside.
Precisely. The injury causes bleeding and swelling within this confined, non-expanding space. As that swelling increases, the intracompartmental pressure rises higher than the capillary perfusion pressure. Eventually, it just collapses the microcirculation and interrupts blood flow and oxygen delivery to the tissues trapped inside that compartment, primarily nerves and muscles.
And the diagnosis, it often relies on that gradual buildup, doesn't it, leading to that lag phase?
Exactly. Diagnosis often requires a gradual extravasation of fluid, a slow leakage, into the compartment. This leads to what's termed the lag phase.
What defines the lag phase?
It's the time from the initial injury until the classic symptom severe pain, often described as pain out of proportion to the injury, and a loss of motor function become clinically apparent. And crucially, this lag phase defines the time interval during which potential intervention might prevent permanent nerve and muscle damage. It's a window of opportunity.
And this is precisely why measuring intracompartmental pressure is so important in suspected cases, right? To objectively assess the severity during that lag phase before it's maybe too late.
Exactly right. The intracompartmental pressure is measured, often serially, and it's compared with the patient's diastolic blood pressure to determine the pressure gradient, the perfusion pressure.
Okay.
And it's also vital to factor in the host status, referring back to the wellness score from Table 1, because a patient's overall health and, frankly, their pain tolerance influence how they present and their threshold for damage at any given pressure.
Makes sense.
Ultimately, the diagnosis of SMCS rests on a combination of compelling clinical findings. The pain, the paralysis, the paresthesias, the pallor, the pulselessness, though pulse loss is a very late sign. And if pressure monitoring is available, objective intracompartmental pressure measurements confirming critically elevated pressure.
Okay. And the pathophysiology of that lag phase, why does it take time to develop?
It's fundamentally a function of that same self-perpetuating edema plus ischemia-hypoxia cycle we detailed earlier.
The vicious cycle again.
The vicious cycle strikes again. The trauma causes initial edema, the pressure rises, this causes ischemia, leading to cellular hypoxia, which causes cellular swelling, creating more edema. further increasing pressure and ischemia. It's this cascade that explains why the lag phase occurs and why it typically takes hours before SMCS becomes clinically apparent rather than being immediate. It takes time for that pressure to build and the cycle to really ramp up.
Got it. So how does HBO intervene in compartment syndrome, specifically targeting this cycle?
Well, the mechanisms are essentially the same as we described for crush injury. It aims to interrupt that edema-ischemia cycle while optimizing oxygen availability within the stress compartment.
Increasing dissolved O2 and the vasoconstriction.
Exactly. Increasing dissolved oxygen availability to tissues despite the poor perfusion, and importantly, causing that vasoconstriction, which helps to interrupt the edema-ischemia cycle by reducing fluid influx, while simultaneously optimizing oxygen availability within the compartment via the dissolved O2.
And the treatment schedule during that lag phase.
The source notes that typically 36 to 48 hours of twice-daily BID, or maybe even 3 times a day TID treatments, are often sufficient to interrupt and potentially reverse the lag phase of SMCS before permanent damage occurs. This is that critical window for intervention.
Okay, 36, 48 hours, B by D or TA. But there's a really important warning here, isn't there?
Absolutely crucial. A non-negotiable caveat. Something that must be stated with absolute clarity. Hyperbaric oxygen must never be used as an excuse to delay a fasciotomy in established manifest SMCS syndrome.
Cannot stress that enough.
Cannot stress it enough. If the clinical findings and the pressure measurements meet the universally accepted criteria for surgical release, a fasciotomy is the priority and must not be delayed by attempting HBO as a sole treatment.
So HBO is indicated in the lag phase if the pressures and host status suggest it's impending but may be reversible.
Correct. When compartment pressure measurements, paired with the host status, provide objective information indicating an impending syndrome that might still be reversible without immediate surgery. Or it can be used as an adjunct after the fasciotomy.
Ah, okay. So if there are residual issues after the fasciotomy.
Exactly. If residual issues from SMCS are present after a fasciotomy has been performed, things like ischemic muscle that looks dusky or questionable, threatened skin flaps over the fasciotomy site showing signs of poor perfusion, indistinct demarcation lines between viable and non-viable muscle or skin, maybe residual nerve impairments from the ischemic insult, or just excessive swelling that's slow to resolve. That HBO is indicated to help facilitate the repair process. This is similar to its use in the repair phase of crush injury, supporting wound healing and tissue viability in those compromised post-fasciotomy tissues.
Okay. And the source has a flow chart for this too, figure 3.
Yes, figure 3 in the source provides a flow chart specifically for skeletal muscle compartment syndrome. It visually shows the progression from a suspected stage, injuries with potential, to an impending or lag stage where signs are present but maybe not severe enough yet for fasciotomy,
Right.
to a manifested stage where you have the classic signs and pressure measurements requiring immediate surgery. And it clearly shows how HBOs fits into the management algorithm for that impending lag stage.
Where does it show HBO fitting in?
It recommends the 36 to 48 hours of TID or BID treatments during that critical window of the impending lag stage. And it also clearly shows the option for using HBO after fasciotomy, if needed for persistent or residual healing issues. That flowchart is a really valuable visual guide for the decision process.
Yeah, that flow chart in figure 3 really helps nail down the timing and the decision points. It seems the absolute sweet spot for HBO is definitely that impending or lag stage, trying to head it off before it becomes a full-blown fasciotomy requiring syndrome.
That's the ideal scenario for its use as a primary intervention.
But that warning, that absolute rule about not delaying a necessary fasciotomy is just paramount. You cannot use HBROs to try and avoid a needed surgical release if the criteria are met.
Absolutely not. Fasciotomy first if indicated.
That feels like a classic point for, board exams or just real-world critical thinking. When is HBROs indicated in SMCS? Answer: in the lag phase, supported by objective pressure host status data. When is it absolutely contraindicated as a primary treatment? Answer: as a substitute for a required fasciotomy.
Spot on. Those are the key takeaways.
All right, let's quickly consolidate on SMCS then. Core problem: high pressure in a closed muscle compartment causing ischemia often has that critical lag phase before permanent damage. HBOs can interrupt the underlying edema-ischemia cycle during this window, 36-48 hours, BID or TID treatments. The crucial point, emphasized by the source in figure 3, is never delay a necessary fasciotomy.
Never.
However, post-fasciotomy, HBOs can still be helpful for addressing residual healing issues in compromised tissues.
Excellent summary. Now, moving on, let's consider thermal burns.
Okay, burns. How do they fit in?
Well, the source references a more comprehensive section on thermal burns elsewhere in the manual it's drawn from. But it includes burns here because they absolutely share the characteristics of other traumatic ischemias. Particularly, they have similar underlying pathophysiology related to microcirculatory damage and ischemia.
Makes sense. What's the main difference?
The singular difference, of course, is that burns are a trauma resulting from energy transfer, thermal energy, rather than mechanical force or, say, surgical insult.
Got it. Heat versus force.
Right. And burns are actually an excellent classic example of that gradient of injury we discussed earlier.
Ah, okay. How so?
Well, you typically have zones of irreversible damage, the central area of coagulation necrosis. Then surrounding that, you have a zone of stasis tissue that's injured, ischemic, but potentially salvageable if conditions improve. And peripheral to that, a zone of hyperuremia, which is minimally injured but inflamed. Ischemia-hypoxia is a direct consequence of the injury to the microcirculation within those injured zones, especially the zone of stasis.
Okay. And the burn classification helps here.
Yes, the new American Burn Association classification has expanded burns into a 4-component continuum, moving beyond just the traditional depth definitions.
Yeah.
You have first degree, second degree, which includes superficial partial thickness and deep partial thickness, third degree, which is full thickness, and fourth degree, a full thickness involving deeper structures like muscle or bone.
Okay.
These levels of severity, particularly differentiating between deep partial thickness and full thickness, help identify for which burns HBOs is indicated.
Where does it fit best?
Primarily for those deep partial thickness burns. Here, the primary insult is significant damage to the microcirculation, leading to leakage of fluid into the interstitial tissues, creating significant edema. This is very analogous to what happens in SMCS.
Ah, the leaky vessels again.
Exactly. This pooling of fluid contributes to local pressure and worsens ischemia in the already compromised tissue, that zone of stasis. And this pathophysiology helps explain why some clinical reports suggest fluid loss with HBOO treatment in comparable burns is about 30% less than in non-HBOO treated burns. It seems to help reduce that microvascular leakage.
Interesting. Less fluid resuscitation needed, potentially.
Potentially. Now, when the gradient transitions into a full-thickness burn, the situation changes. There you have frank hemostasis, sludging, and coagulation of the vasculature. The vessels are essentially clotted off and destroyed. It's somewhat analogous to the effects you see with electrosurgery in the OR, but caused by heat.
Okay, so what can HBO do there?
In this context, HBOs works by extending circulation and oxygen delivery to the adjacent injured but still viable tissues, particularly that critical zone of stasis. It augments oxygen delivery and can potentially salvage tissue that would otherwise die. So a key goal of HBO in deep partial thickness burns is actually to prevent this potentially viable tissue in the zone of stasis from converting into a full thickness, non-viable burn injury due to progressive ischemia.
Saving the at-risk tissue.
Precisely. And the use of HBOs extends through all 3 phases of the burn injury, targeting the specific challenges of each phase.
How does that break down?
Okay, in the acute inflammatory phase, right after the burn, it provides hyperoxygenation to the ischemic tissues, especially that zone of stasis. It also helps modify the reperfusion injury process that occurs as blood flow tries to resume. Both of these are helpful in maintaining tissue viability and preventing that conversion to full thickness.
Okay, acute phase. Prevent progression. What about the repair phase?
In the repair phase, the source notes a significant clinical benefit based on reports. Approximately a 30% decrease in the need for skin grafts compared to burns of comparable degree treated without HBO.
30% fewer grafts. That's substantial.
It is. It helps the healing processes by fueling angiogenesis, new blood vessel formation, promoting the formation of healthy granulation tissue, which is the necessary base for skin grafts to take, supporting keratinization, skin cell growth over the wound, and enhancing the survival of threatened skin grafts by improving their oxygen supply.
So, better healing, fewer grafts needed. Any other benefits?
Reports also indicate reduced hospital length of stays, often by about 1/3, which is obviously a substantial benefit both clinically and economically.
Okay. And the remodeling phase?
Finally, in the remodeling phase, it helps with normalizing skin appearance, reducing the redness, erythema, and significantly reducing scarring.
How does it reduce scarring?
This is attributed to mitigating the hypoxic environments that can develop within healing tissue. Hypoxia tends to favor the formation of hard, hypertrophic, undesirable scar tissue. By providing more oxygen, you potentially get more organized, less prominent scarring.
Interesting. So benefits across all 3 phases for burns.
Yes. And as in crush injury, the frequency and number of HBO or treatments for burns would depend on the function of the healing phase in which it's being used and the clinical goals at that time.
Okay. Let's move on to frostbite or cold injury. How does that fit the traumatic ischemia model?
Right. Here, the trauma is obviously from cold injury rather than mechanical force or heat. There is one significant difference compared to the other traumatic ischemias we've discussed.
What's that?
In cold injury, the injured tissues often remain frozen. But in the absence of intracellular ice crystal formation, the cells can actually survive for some time. The source describes this initial frozen phase as a kind of golden period where cellular metabolic activity is drastically reduced. It's analogous to tissue preservation during hibernation.
So the tissue is preserved while frozen as long as ice crystals don't form inside the cells.
Generally, yes. The critical time for potential tissue injury, or conversely for salvage, is actually during the rewarming process. This is when the damage truly declares itself, or when intervention can make the biggest difference.
So the initial cold causes the potential for injury, but the actual tissue destruction or the opportunity to save it really happens during the thaw.
Precisely. That's the crucial window. Because during rewarming, you have the inflammatory process kicking in aggressively, especially within the microcirculation.
What happens then?
You get sludging of blood cells, rouleau formation, the red cells stacking up, thrombosis, clot formation blocking vessels, leakage of intracellular fluid from cells damaged by hypoxia during the freeze-thaw cycle, and significant swelling, edema. All of these things further compromise blood flow and oxygen delivery just when the tissue is trying to recover metabolically.
So rewarming triggers an inflammatory storm that can worsen the injury.
It can. The treatment approach, according to the source, is that all measures aimed at improving perfusion, whether pharmacological agents like thrombolytics or anticoagulants, or supportive measures like aggressive fluid resuscitation, should be combined with the hyperoxygenation effect of HBO during the rewarming management of these frozen tissues.
So use HBO alongside things like TPA or heparin during the thaw.
That's the suggestion. The goal is to minimize that damaging inflammatory cascade and restore blood flow while simultaneously providing maximum oxygen delivery via the dissolved plasma route to support the recovering cells.
Okay, and after the initial rewarming?
For the indication of HBO, once that initial critical rewarming phase is managed, cold injury becomes similar to crush injuries and thermal burns regarding its application in the other phases of healing, the repair, and remodeling phases as those damaged tissues recover over time.
Got it. Critical during rewarming then follows similar principles later. Now, what about threatened flaps and grafts? You mentioned them earlier. They might not seem like typical traumatic ischemias initially.
Right, at first glance, maybe not. But the source explains they absolutely meet the criteria because the trauma can originate in two ways.
Okay.
First, the initial injury itself might have created threatened flaps or necessitated the use of grafts. Think of a severe open fracture with degloving, or a large defect requiring coverage. That's direct trauma.
Right.
Second, and this is a critical point, especially for surgical specialists, the surgical trauma associated with debridement, flap elevation, graft harvest, or even amputation surgery cannot be discounted. The surgical insult itself contributes to tissue injury, swelling, and potential ischemia in the reconstructed tissues.
So the surgery itself is a form of trauma relevant here.
Absolutely. Now, the key point here, maybe in contrast to crush injuries, where the degree of the initial mechanical insult and the resulting ischemia is paramount. For threatened flaps and grafts, the importance often lies more in what is needed for that specific skin graft or flap to survive and integrate with the recipient bed.
Okay. What does that mean for HBO?
It means that when hypoxia, meaning compromised blood flow and oxygen delivery, is a component of that need, when you see clinical signs of poor perfusion threatening the viability of the flap or graft, that's when the hyperoxygenation effect of HBOs becomes apparent and potentially very helpful.
So if the flap looks dusky or the graft isn't taking because of poor oxygenation?
Exactly. HBRs has significant utility in optimizing the repair phase of wound healing for threatened skin grafts, specifically by its hyperoxygenation effect. It helps those grafts get the oxygen they need to establish a blood supply from the wound bed and successfully integrate.
Makes sense. And for flaps, especially after major trauma?
Yes. In the context of severe crush injury, particularly those Gustilo Class 3B and Class 3C fractures, where large complex flaps are often required for coverage. HBO's role in flap survival is undoubtedly its most important effect.
Why is it so critical there?
Well, major orthopedic trauma often necessitates major limb reconstruction surgery. And the crucial variable for tissue survival in these complex reconstructions is often the degree of underlying soft tissue injury and the status of the vascular supply to the flap.
Right, the flap needs its own blood supply.
It does, and the beneficial effects of HBO seem to be most apparent during that acute inflammatory stage immediately after the flap surgery. It helps reduce edema in the flap and provides that crucial oxygen diffusion to the flap margins, which are often the most tenuous parts.
So starting HBO early after flap surgery is probably better.
That's the strong suggestion.
Mm.
Starting HBO earlier after flap surgery is more likely to help with flap survival. The previous comments we made regarding crush injury protocols, particularly the emphasis on early and frequent treatment, are directly applicable to the threatened flap in that specific context.
Okay. And later on in the remodeling phase?
In the remodeling phase of wound healing, HBOs can also play a role. It can help by addressing persistent wound sloughs, aiding demarcation of viable from non-viable tissue if parts of the flap didn't survive, and mitigating infection, particularly if osteomyelitis is an underlying concern in the bone beneath the flap.
Got it. Now, related to this, threatened and/or failing amputations, how do they fit the model?
They also qualify as traumatic ischemias.
Right.
In these situations, the trauma is really twofold. First, there's the initial injury, which severely compromised the limb in the first place, leading to the decision for amputation.
Right.
And second, there's the surgery itself, which, while necessary and hopefully gentle, is still an insult to the tissues used to create the stump, the amputation flaps. This is coupled with the pre-existing ischemia-hypoxia of the tissues that actually necessitated the amputation.
So, underlying poor circulation plus surgical trauma.
Exactly. While meticulous technique is always the goal, any surgery inherently involves tissue handling, clamping of blood vessels, retraction of tissues, and the unavoidable introduction of some bioburden, some bacteria. Surgery triggers the release of all those inflammatory agents, growth factors, cytokines, prostaglandins, those cluster designations, which induce pain and swelling. These are typical inflammatory stage responses.
Okay.
And that preoperative ischemia-hypoxia is often what contributes to the decision to perform a major amputation in the first place, typically at or above the forefoot level in the lower extremities. It's really incumbent on the surgeon to recognize signs of this pre-existing issue or potential intraoperative compromise, both during and immediately after the surgery.
What signs suggest the amputation might be threatened?
Findings suggestive of a threatened amputation site include things like minimal bleeding from the cut tissue edges, especially in the absence of a tourniquet, maybe even if the patient is anticoagulated. Also, pallor or coolness of the skin flaps compared to surrounding tissue, and delayed capillary refill time. These are all clinical signs pointing towards ischemia and hypoxia in the remaining tissue flaps.
Okay. So when should HBO be considered here?
The window of opportunity for using HBO to try and prevent failure sloughing of the flaps, wound breakdown, dehiscence, is immediately upon completing the surgery, right when those tissues are in the acute inflammatory and ischemic phase from both the underlying condition and the surgical trauma.
So aggressive early treatment again.
Yes. The source recommends an aggressive HBO treatment schedule here to maximize the chance of salvaging those marginal flaps. 3 treatments within the first 24 hours after surgery, and then twice a day for the next 2 days.
Wow, that's intensive. 3 times day 1, BID days 2 and 3.
It is. This schedule is specifically aimed at addressing that acute inflammatory ischemic stage in the amputation flaps. Now, if flap failure occurs later, maybe due to delayed healing or infection creeping in, then twice a day or daily, HBO is recommended to support and challenge the repair stage of wound healing in the compromised stump.
Okay. Different approach for later problems. Finally, what about threatened reimplantations?
Right. Threatened reimplantations are presented as an additional consideration for HBO in the realm of traumatic ischemias, a unique challenge.
How are they similar or different?
The justifications for using HBO were similar in principle to those for threatened flaps, grafts, and amputations. You're dealing with tissue compromise and ischemia. However, there's typically less gross, blunt trauma to the tissues right at the reattachment site compared to, say, a severe crush injury. It might be a cleaner cut.
Okay, so what are the main challenges in replantation?
The primary challenges in successful reimplantations, particularly of things like digits or maybe even larger limb segments, are twofold. Ischemia-hypoxia, especially if the arterial repair is tenuous or took a long time. Right. And, very commonly, venous congestion. Difficulty getting blood out of the replanted part effectively.
Ah, the drainage problem. How does HBO help with both?
Well, it helps address both. It improves oxygenation throughout the replanted tissue via the dissolved oxygen mechanism, helping to compensate for potentially compromised arterial inflow. But simultaneously, it helps by decreasing venous congestion via its vasoconstriction mechanism.
Wait, vasoconstriction helps venous congestion?
How? While vasoconstriction elsewhere might reduce inflow, in a congested state, constricting the arterioles slightly can reduce the amount of blood flowing into the replanted part, while the improved oxygenation helps the tissue tolerate the temporary congestion better. It sort of balances the inflow and outflow problem. While arterial inflow can usually be reestablished with microsurgery, adequate venous outflow, especially from small vessels like in digits, is not frequently the case. It's often the Achilles heel.
Right. And leaching is sometimes used for that venous congestion.
Exactly. Leaching has historically been, and remains, a useful adjunctive therapy to address this venous congestion outflow challenge by physically removing the pooled venous blood.
So should HBO and leaching be used together?
The source states that the combination of HBO and leaching, when venous congestion is observed, should be done immediately upon appreciation of the issue, usually right at the time surgery is completed or very shortly thereafter, when the tissue is in that acute phase of vascular compromise.
Okay, immediate combo therapy if venous outflow is poor, and if the replant fails later.
If the reimplantation fails later on, maybe due to infection or other healing complications, then the comments we made regarding threatened flaps, grafts, and amputations for supporting the repair stage of wound healing are applicable. You treat it based on the principles for that stage.
Wow, okay. That covers a really wide range of complex injuries and scenarios. It definitely seems the core principles of HBO Euro, boosting oxygen where perfusion is poor, controlling edema, supporting key healing cells, they really apply across these different situations.
They do.
Although the specific timing and the main emphasis might shift depending on the exact condition, whether it's preventing burn conversion, managing frostbite rewarming, supporting a flap acutely, dealing with venous congestion in a replant, and which stage of healing you're currently in.
That's a perfect way to summarize it. The principles are consistent, but the application is tailored.
Okay, let's do a quick specific summary for these other conditions then. We saw how HBORO can help in burns, primarily by targeting that microcirculatory damage, trying to prevent partial thickness burns from converting to full thickness.
Right, saving the zone of stasis.
Then aiding healing and grafting success in the repair phase, potentially reducing graft need by 30%, and finally, reducing scarring in the remodeling phase.
Correct.
In frostbite, its key immediate role is during that critical rewarming phase, where it's used in conjunction with other measures like thrombolytics or anticoagulants to improve perfusion and limit reperfusion injury.
Crucial timing there.
For threatened flaps and grafts, especially in the context of severe crush injuries, it's critical in the acute phase right after surgery to optimize oxygen delivery, supporting survival and helping demarcate viable tissue. Later on, it can help with infection control.
Yes, early intervention is key for flaps.
In threatened amputations, it's about aggressive immediate post-op treatment TID day 1, BD days 2 and 3 to try and salvage marginal tissue in that acute ischemic phase, and then potentially supporting the repair phase if healing complications arise later.
Right, hitting it hard early.
And finally, for threatened reimplantations, it's used immediately post-op, often in combination with leaching if needed, to address both the ischemia-hypoxia and the venous congestion, with later application for repair challenges if they arise.
You've nailed the key points for each of those specific conditions. The common thread is always addressing the ischemia and supporting the healing environment, but tailored to the specific pathophysiology and the stage of healing.
Excellent.
Okay, now let's transition into the discussion section of the source material, starting with some broader considerations around decision-making, the evidence base, and the challenges encountered in practice.
Okay.
So the traumatic ischemias, as we've really established now, they have many unifying features. They share similar underlying pathophysiology, they present as continua of injuries from mild to severe, and they have predictable complications that arise when that pathophysiology isn't adequately addressed.
Wow.
Now, perhaps the most important observation for you, the clinician managing these cases, is recognizing those subtle, or maybe not so subtle, signs of impending or suspected less than desirable outcomes.
Picking up on trouble early.
Exactly. The source makes a really strong plea here that any suspected less than desirable observation from this whole spectrum of traumatic ischemia disorders, whether it's a flap looking a bit dusky, pain increasing out of proportion, capillary refill slowing down, or just that gut feeling that a wound isn't healing right. That observation should be given immediate, serious attention. And this includes active consideration of HBO utilization as a potential adjunctive therapy right at that moment. Don't wait and see if it gets worse.
Be proactive if you suspect trouble.
Be proactive. Now, regarding the evidence base, just to recap briefly before we dive deeper, for open fractures with significant crush injury components and for burn injuries, the source states that 2 randomized controlled studies, which we'll detail further shortly, show about 30% or more decreases in complications compared to blinded controls receiving state-of-the-art care without HBO.
Okay, RCT evidence for crush and burns showing 30% fewer complications.
Right. For skeletal muscle compartment syndromes in the lag phase, while the evidence is more limited, one report indicated that when HBO treatments were started in that specific window, no compartment syndromes progressed to the point requiring fasciotomies.
Interesting, but limited data for SMCS lag phase.
Correct. And for the other traumatic ischemias we discussed, frostbite, threatened flask grafts not associated with crush, threatened amputations, reimplantations. Most of the information and support for using HBO comes from anecdotal reports and accumulated clinical impressions gained over years of experience rather than high-level trials.
So, varying levels of evidence depending on the specific condition. Okay, so let's bring it all together now for a comprehensive recap of the core content we've been through. This has been a lot of detail.
It has. Let's consolidate.
We started by defining acute traumatic ischemias, highlighting that significant problem of high complication rates, 50% or more, even with optimal conventional care.
Right, setting the stage.
We then really dove into the fundamental science, centering on trauma plus ischemia as the core issue. We talked about that vicious edema ischemia-hypoxia cycle, visually represented in Figure 1, that drives progressive damage. And the concept of the gradient of injury, distinguishing viable from non-viable tissue.
The core pathophysiology.
Yeah, exactly. We walked through the 3 distinct stages of wound healing, inflammatory, repair, and remodeling, explaining the unique oxygen needs and cellular activities in each stage. And critically, how HBO specifically intervenes at each stage, using its core mechanisms. Increased dissolved oxygen getting past blockages, vasoconstriction for edema control, and providing essential oxygen fuel for those critical healing cells like fibroblasts, macrophages, keratinocytes, and especially those oxygen-hungry osteoclasts.
Mechanisms of action.
Then we covered the general protocols and timing, emphasizing the importance of early treatment in the acute ischemic phase, 3+ treatments in 24-72 H's, and outlining the different durations for the repair phase, daily bide for 14 days, and the remodeling phase, daily for 3-6 weeks for bone, all depending on the clinical goal.
Tailoring treatment to the phase.
We detailed the application in crush injuries, explaining how the objective wellness score from Table 1, assessing the patient's host status,
Right.
and the Gustilo classification from Table 2 and Figure 2, assessing injury severity, are combined to guide decision-making, including that crucial salvage versus amputation consideration, especially in impaired compensated hosts with severe injuries.
The decision-making framework.
We then explored the specific uses and considerations for SMCS, highlighting the critical lag phase and that absolute rule about not delaying fasciotomy if it's indicated, as shown in Figure 3.
Crucial point for SMCS.
We covered burns preventing conversion, aiding healing and grafting, reducing scarring, frostbite, its specific role during the rewarming phase, threatened flaps and grafts optimizing oxygen for survival and demarcation, especially vital in severe trauma. Threatened amputations, the need for immediate post-op intervention for acute ischemia, and threatened reimplantations addressing both ischemia and venous congestion, often alongside leaching.
Covering the specific conditions.
And finally, we touched on the clinician's vital role in recognizing those early signs of suboptimal outcomes as a trigger for considering HBO, and briefly mentioned the varying levels of evidence supporting its use, noting the strong signal from randomized controlled trials in crush injury and burns.
That is an excellent, really comprehensive recap of all the key elements we've covered so far in the core content.
Good. It's a lot to absorb.
It is. So now let's delve a bit deeper into those discussion points outlined in the source. We'll start by maybe reiterating the unifying features and the differences among these conditions, and then move into side effects, economics, peer review, and look at the evidence in more detail.
Okay, sounds good.
So as we've established, while these traumatic ischemias appear as different clinical entities, a crush looks different from a burn, looks different from frostbite or a failing flap.
Right.
They share fundamental unifying features. They all involve trauma, whether it's mechanical, thermal, or surgically induced. They're all characterized, to varying degrees, by that self-perpetuating edema-ischemia-hypoxia cycle. And they all present with a gradient of injury, that spectrum from healthy tissue to dead tissue, with that critical zone of compromised but viable tissue in between.
The common ground.
The common ground. However, they also have important differences. The amount of trauma varies greatly. From the maximal tissue destruction you see in severe crush injuries and Gustilo class 3B, class 3C fractures, down to the relatively minimal gross trauma may be seen at the reattachment site in a clean reimplantation. Threatened flaps and amputations fall somewhere in between, involving that combination of initial injury plus the surgical trauma.
Okay, other differences.
The predominant pathophysiological features can also differ in emphasis. While they all involve ischemia-hypoxia, the dominant driver might vary. For example, in a burn injury, the ischemia-hypoxia is primarily secondary to the direct microcirculation injury and the resulting leakage. Whereas in a crush injury, the predominant feature might be the mechanical compression caused by massive edema and bleeding within a confined space.
Right.
In reimplantations, as we noted, venous congestion can sometimes be just as significant a problem as the arterial inflow compromise. So the primary issue can differ.
Got it. And the mechanisms of HBO, do they differ?
Not the mechanisms themselves, but their relative importance can vary. While the core mechanisms increased, dissolved oxygen, vasoconstriction, anti-edema effects, support for host defenses, and infection control are consistent across these conditions. Their relative importance might shift depending on the specific stage of healing and the specific type of traumatic ischemia you're treating.
So you might emphasize the anti-edema effect more acutely and the support for osteoclasts more chronically?
Exactly. And as we've emphasized throughout, the timing of intervention matters greatly. Immediate HBO is key when ischemia-hypoxia in the acute inflammatory stage is the main concern, like in the lag phase of SMCS, and acute crush, or immediately post-replantation or amputation.
Right.
However, delays in treatment don't necessarily negate the value entirely. If bone infection or fracture healing is delayed due to persistent ischemia-hypoxia impacting the remodeling phase, HBO still has a crucial and indicated role, just with a different treatment schedule, as we discussed.
Okay, that clarifies the similarities and difference as well. What about side effects? That's always a concern with any treatment.
Absolutely. As with any intervention, particularly one that's an adjunct to already complex management strategies for severe injuries, considerations of cost-benefit and the principle of do no harm, primum non nocere, are paramount.
Especially relevant here.
Especially relevant for using HBO or in traumatic ischemias, as it is an intensive therapy involving pressure changes.
So how safe is it, according to the source?
The source states clearly that using HBO according to the established guidelines, like those from the Undersea and Hyperbaric Medical Society, the UHMS, is inherently safe. While potential side effects exist, they are generally rare when protocols are followed correctly.
What are the main ones to be aware of?
One potential side effect is barotrauma, specifically to the ear membranes, caused by the pressure changes during compression and decompression.
Ear pain or problems clearing?
Exactly. This can occur to some extent in patients who have difficulty clearing their ears, maybe due to swelling or pre-existing issues. But it rarely prevents treatment altogether and can typically be managed, for instance, with myringotomy tubes placed across the eardrums to equalize pressure if needed for multiple treatments. The source notes its rarity, perhaps occurring in one case in 10,000 pressurizations, leading to significant issues.
Okay, ear barotrauma is possible, but usually manageable. Anything more serious?
A more serious, but even rarer potential side effect is central nervous system, or CNS, oxygen toxicity. This can result in seizures.
Seizures, how common is that?
Very rare during hyperbaric conditions, according to the source, perhaps one case in 10,000 treatments. When it does occur, it's often associated with underlying predisposing conditions in the patient, such as a known history of seizures or concurrent problems like high fever, acidosis, or hypoglycemia.
So risk factors increase the chance, but overall it's very infrequent.
Very infrequent. While other potential side effects like pulmonary oxygen toxicity or ocular issues, like temporary vision changes, might be discussed in other sections of the manual, the source specifically highlights ear barotrauma and CNS oxygen toxicity as the main considerations in the acute management context of traumatic ischemias.
Okay, low risk overall, but things to monitor. What about economic considerations, the cost-benefit picture?
Right. The source describes the cost benefits of using HBO for traumatic ischemias as more elusive to precisely determine and quantify in broad economic terms compared to assessing side effects.
Harder to put a dollar value on.
It is. Of course, every clinician seeks to achieve the best possible functional and anatomical outcomes for their patients, minimizing disability, minimizing suffering. The adjunctive use of HBO in traumatic ischemias helps meet this highly subjective but deeply important clinical goal for individual patients.
Right, the goal is the best outcome, regardless of cost sometimes. But is there objective data?
Well, more objective information about the economic benefits is strongly suggested, though not always explicitly calculated in dollars, by the outcomes reported in those randomized controlled crush injury and burn injury studies we mentioned.
How so?
Those reports uniformly show that HBO reduces complications by that significant 20 to 30% margin compared to state-of-the-art care without this modality. This is particularly true in severe tissue trauma, like the Gustilo class 3BC fractures, or deep partial thickness burns, which are inherently associated with 50% or higher complication rates, even with the best conventional treatment.
So fewer complications means lower overall costs, presumably.
That's the strong implication. Framing this significant reduction in complications, preventing subsequent surgeries for infection or non-union, reducing hospital length of stay, potentially preventing or limiting the extent of an amputation, preserving function, reducing long-term disability, and rehabilitation needs. It highlights the potential for significant economic benefit, even if it's difficult to put a precise dollar figure on it across large populations. Preventing just one major complication like an amputation or chronic osteomyelitis clearly has substantial downstream cost savings, even if the cost of the HBO treatments themselves is significant upfront.
That makes sense. Investing upfront to save much more later.
That's the argument. Now, related to cost is peer review, meaning the ongoing evaluation and decision-making regarding the continuation and discontinuation of HBO treatments.
Right.
This is also an important economic consideration.
Deciding when to stop treatment.
Exactly. Sound decisions, balancing cost, and potential benefit are made by pairing the specific wound healing stage for which HBOs is indicated with the desired durations of treatments, as we outlined in the protocols.
Right. Matching duration to the goal.
Exactly. For example, as we discussed, if HBO is being used primarily to improve oxygen availability during the acute inflammatory stage to salvage marginal tissue, 2 to 3 days of treatments are usually sufficient. Further treatments may not provide additional benefit for that specific acute goal and just add cost.
Yeah.
If the goal is supporting the repair phase for a compromised flap, then 14 days of treatments is typical. And for addressing bone infection or delayed union in the remodeling stage, about a month, maybe 3 to 6 weeks, of treatments is often needed because bone healing is inherently slow.
So who makes the call on stopping?
Decisions regarding continuing or discontinuing HBO treatments should ideally be a joint decision between the referring physician, who understands the overall patient status and the surgical context, and the hyperbaric physician, who understands the specific effects, timelines, and limitations of HBO therapy. The important factor in this determination is always the stage of healing in which the HBO is being considered and the specific therapeutic goal being targeted at that time.
Collaborative decision based on the phase and goal.
Got it. Now, let's circle back and look at the evidence review in more detail. You mentioned varying levels.
Yes. While the published evidence specifically justifying the use of HBO for all traumatic ischemias may not be as universally rated as robust level 1 evidence across the board compared to, say, the soundness of its underlying mechanisms or its demonstrated ability to mitigate known pathophysiologies. An analysis of the available evidence, when taken as a whole, does uniformly support the benefits of using HBO for these injuries, particularly the severe ones.
Okay. What types of evidence are included in this review?
The evidence reviewed includes several prospective reports, one head-to-head comparative study, though flawed, and those 2 specific randomized controlled trials we keep mentioning.
Okay.
The source details an early, somewhat dated retrospective study, the Strauss HBO review from 1981. This was a large review, compiling over 700 anecdotal case reports of crush injuries and other traumatic ischemias treated with HBO.
700 cases is a lot, even if anecdotal. It is. But as it was retrospective and based on individual case reports, the data lacked formal grading systems for the injuries or objectively qualified outcome measures. It was based on clinician reports.
So subjective assessments mainly.
Mainly. However, the specific subjective comments reported by the traumatologists who referred the patients and reported the outcomes were quite striking and very consistent. They included phrases like, Fewer complications than expected, fewer surgeries required for equally severe injuries, observations of accelerated edema reduction, reports that injuries of similar magnitude would have had bad outcomes without HBO, and frequent observations of survival of tissues that otherwise would have sloughed.
So a lot of strong clinical impression and qualitative observation in that early review, seeming to paint a picture of significant benefit. Was there any objective takeaway from that large anecdotal data set?
Yes, interestingly, the single objective takeaway that emerged clearly from that 1981 review, despite its methodological limitations, was a dose-response relationship related to the timing and frequency of initial treatment.
Ah, the early treatment importance again.
Exactly. The more frequent the initial HBO's treatment, the better the reported outcomes. The specific examples given were quite compelling. 6 treatments initiated within the first 24 hours generated 100% positive outcomes as reported by the clinicians.
6 treatments in 24 hours. Wow.
Yeah, very intensive. Whereas 3 treatments yielded 80% positive outcomes, and just a single treatment yielded only 59% positive results. This strongly reinforced the idea that early, frequent treatment targeting that acute inflammatory phase was crucial. Remember, more frequent early treatments.
Correlated with better outcomes in that large, early anecdotal review. That's a really strong signal, even if it's not level 1 evidence, and it fits perfectly with the pathophysiology we discussed, hitting that critical inflammatory phase hard when oxygen need is highest.
Exactly right. Good connection. And that intuition, that early signal, was later supported by more structured reviews and studies. A second review was published 24 years later by Garcia-Covarrubias in 2005.
Okay, what did that find?
This review applied stricter criteria for including studies. It provided 9 documents that met their criteria for an evidence-based approach, totaling about 150 patients included in case series reports. Most of these were still retrospective studies lacking standardized methodology compared to modern trial design, however.
But what was the conclusion from those 9 studies?
8 of the 9 studies included, so 89%, showed a beneficial effect from HBO.
Okay, still a strong positive signal.
It was. It's noteworthy, though, and perhaps reflects the lack of structured data in the earlier reports, that only one of the citations from that big 1981 review had enough statistical detail to even be included in this later, more evidence-focused review.
Interesting. What about prospective studies, any of those?
With respect to prospective studies, the source mentioned some case reports emerging from military conflicts, specifically in Croatia and Israel, which were also referenced by Garcia-Covarrubias.
Wartime injuries.
Yes. These were observational reports suggesting that limb salvage and enhanced healing occurred with adjunctive HBO for severe war-related lower extremity injuries, which are often devastating crush-type injuries. Formal wound classifications weren't always apparent in the reports, but the perceived value of HBOs was attributed to its help in managing the incredibly complex soft tissue components of these injuries.
Okay. And that head-to-head study you mentioned was weak.
Yes, a head-to-head comparative study by Caudle and Matos from 1999 is mentioned, but described as weak. It reportedly showed 78% better outcomes with HBO for limb salvage compared to a control group. However, the study was small, comparing 62 patients to 62 controls. It was only ever reported as an abstract, not a full publication, and the seriousness of the injuries was not clearly delineated or controlled for between the groups. So its strength as definitive evidence is significantly limited.
Got it. Suggestive, but not strong. So where is the strongest evidence?
The strongest evidence specifically for using HBOs for the crush injury component of traumatic ischemias, particularly those severe open fractures, comes from those 2 specific randomized controlled studies we keep mentioning.
Bouchard and Millar.
Bouchard and colleagues, published in 1996, and Millar and colleagues, published more recently in 2022. Although their specific study methods differed somewhat, Bouchard used a crossover design, Millar used a standard parallel group RCT. The clinical outcomes they reported were remarkably similar, and both supported a significant benefit for HBO.
What were the key findings?
The Bouchard study, looking at severe open fractures, reported 94% primary healing, meaning healing without needing major secondary procedures like flaps or dealing with deep infection or non-union in the limb randomized to receive HBO. That compared to only 56% primary healing in the control limb that did not receive HBO.
94% versus 56%. That's a huge difference.
A massive difference. The Miller study, focusing on severe limb injuries with significant soft tissue damage, reported 71% primary healing versus 47% in controls. Still a very substantial improvement.
Still a big gap. Other findings.
Both studies also reported a reduced need for returns to the operating room for complications in the HBOROS groups. Brochure reported particularly better outcomes in patients over 40 years old, suggesting HBOs might help overcome some age-related healing challenges. And Mueller reported 24% less delayed complications overall in the HBO group, things like non-unions of the fracture or deep infections like osteomyelitis developing later on.
Okay, so two RCTs showing very significant benefits for severe crush-open fracture injuries. What about for compartment syndrome again?
Right. For skeletal muscle compartment syndromes, the source confirms that minimal clinical reports specifically demonstrate the value of HBO in their management. This is likely because that window of opportunity in the lag phase is narrow, and the standard of care rightly dictates immediate fasciotomy if the syndrome is clearly established.
So hard to study clinically in that window.
Very hard. However, there are highly sophisticated canine laboratory studies done by Hargens and colleagues back in 1983 and 1986. These are critical pieces of evidence.
What did the animal study show?
These studies conclusively demonstrated the physiological value of HBO in mitigating the pathophysiology of SMCS. They showed it significantly reduced the increase in compartmental pressure caused by ischemia in controlled experimental models. This provides a really strong mechanistic rationale for its use.
Okay, strong lab data supporting the how. Any clinical hints?
There's that single retrospective clinical study by Strauss from 1989. It showed that when HBOs started during the lag phase of SMCS in a small series of patients, no syndrome progressed to the point where a fasciotomy was actually required.
Provocative finding, but small and retrospective.
It's exactly. Needs more study, but it's suggestive. The same series also showed that patients referred for HBO treatments after a fasciotomy had already been performed did show benefits, things like reduced edema, survival of marginally viable tissue, enhanced demarcation of non-viable tissue, and better healing, particularly noted in impaired and decompensated hosts.
Okay.
And occasional single-case reports pop up in the literature showing HBO as a useful adjunct in managing SMCS, usually in complex or delayed presentations. As for evidence for the other traumatic ischemias, burns, threatened flaps, cold injury, etc., the source mentions that this can be found in the respective sections of the manual, often consisting of case series, expert opinion, and physiological rationale rather than level 1 RCT evidence for each specific indication.
Got it. So what are the main conclusions from this whole evidence review then?
Okay, summarizing the conclusions from the evidence. First, the benefits for crush injuries, particularly severe open fractures, seem uniformly verified in nearly 1,000 published cases across multiple study types, importantly including those 2 randomized controlled trials.
Okay, strong for crush.
Second, the overall evidence analysis combining the mechanistic data, the case series, the clinical experience, and the trials where they exist suggests that while HBOs is definitely not a cure-all for traumatic ischemias,
Right.
it consistently shows outcomes, at a minimum 20% better than controls and/or what is reported in the literature for state-of-the-art care, without HBO for comparable severe injuries. That's a significant improvement signal.
20% better is substantial in these bad injuries.
It really is. Third, based on the strong mechanistic data from labs like Hargens and the limited but suggestive clinical reports like Strauss's, HBO should be considered a valid third option after surgery, and standard medical options have been optimized, especially when there is no other logical intervention available in that crucial lag phase of SMCS.
The what else can we do scenario in the lag phase.
Exactly. Because the mechanisms of HBO, particularly reducing edema and increasing oxygen diffusion, are specific, targeted interventions addressing the underlying pathophysiology of traumatic ischemias in a way that other therapies simply cannot during that specific window.
Okay, that's a very clear summary of the evidence landscape. It highlights the strong areas like crush injuries and burns from RCTs, and where the evidence is more limited but still points towards a benefit, often backed by strong mechanistic data like for SMCS. So, to consolidate the evidence discussion again, we have level 1 evidence from RCTs for crush injuries and burns showing a significant 20-30% or more reduction in complications. For SMCS, there's strong animal lab data supporting the mechanism, and that single retrospective report suggesting it might prevent fasciotomy in the lag phase. Early anecdotal evidence pointed to benefits and reinforced the need for frequent early treatments, a principle seemingly supported by later RCT outcomes. Later reviews supported a general benefit across case series. The overall conclusion seems to be that the evidence, while varying in robustness depending on the specific indication, consistently supports the use of HBO, particularly when it directly targets the specific pathophysiological problems of ischemia and edema, where conventional treatments have limitations.
Exactly right. That captures the nuance well. Now, let's move into a really critical section discussing the dilemmas.
Okay, the challenges.
Yes. Despite the strong physiological rationale, the known mechanisms, and the evidence demonstrating significant clinical benefit in severe cases, there are major reasons why HBOs is not more widely used for traumatic ischemias, particularly in the United States.
Why not? If it works.
The source identifies these roadblocks as threefold: accessibility, reimbursements, and attitudes.
Accessibility, reimbursements, attitude. Okay, let's break those down. Accessibility.
Accessibility is a huge practical issue. There are an estimated 70 to 150 facilities, maybe more now, in the United States that have hyperbaric chambers. But only an estimated 5% of those facilities are truly willing or equipped to handle acute, critically injured patients requiring emergency or urgent hyperbaric treatments 24/7.
Only 5% can handle emergencies. Why so few?
It means the vast majority of facilities are primarily set up to treat stable outpatients with chronic conditions like non-healing diabetic foot ulcers or late effects of radiation injury. Acute traumatic ischemias require an accessible, readily available service, staffed by personnel trained in critical care, often needed on very short notice, day or night. That's simply not the operational model for most hyperbaric centers. They aren't typically integrated into acute trauma workflows.
Okay, so just getting access to a suitable chamber quickly is a major hurdle. What about reimbursements?
Reimbursements are arguably the single most significant impediment to the widespread use of HBOs for acute traumatic ischemias.
How so?
Medicare and many other insurance providers often do not reimburse for HBO treatments when the patient is admitted under diagnosis related to a diagnostic-related group, a DRG, other than a few specific emergent conditions like decompression sickness, the bends, or arterial Gatz embolism.
So if the patient is admitted for, say, a severe crush injury under a trauma DOG,
Right.
the HBO treatments they receive, even if clearly helping, might not be paid for.
That's often the case, even if the HBOs is demonstrably improving their outcome, preventing complications, potentially reducing overall hospital costs. The costs of the HBOs treatments themselves may not be covered because the primary reason for their hospitalization, their admission DRG, falls under a different diagnostic category that doesn't have HBOs explicitly listed as covered for that DRG. It's a major systemic bureaucratic barrier to providing the treatment.
Wow. That seems like a huge disincentive for hospitals.
It absolutely is, which leads directly to the third dilemma: attitudes.
Attitudes. Whose attitudes?
The reluctance of administrators at major trauma centers to invest in and fully support hyperbaric medicine programs that can handle emergencies is, frankly, understandable given the other two obstacles.
Because of the accessibility and reimbursement problems?
Exactly. It's a significant upfront investment in infrastructure. The chamber itself is expensive, plus specialized staffing, ongoing training, maintenance, all for a service that is hampered by major issues of accessibility for acute patients and faces significant barriers to getting reimbursed reliably.
A tough sell financially.
A very tough sell. The source notes that to navigate or sometimes resolve these obstacles, insurance carriers often use cutouts.
Cutouts.
This can refer to things like complex pre-authorization processes, very restrictive coverage criteria, or specific policy exclusions that make obtaining reimbursement for off-label or non-DRG-aligned indications incredibly difficult and burdensome for both the hyperbaric facility trying to provide the service and the referring hospital or physician.
So more bureaucratic hurdles.
More hurdles. Now, a potential secondary benefit of anticipated research, particularly from academic institutions, the source suggests, is the generation of a wealth of data that could potentially help overcome some of these barriers by demonstrating value more clearly.
More research needed to prove the case.
Yes, this research is needed because, frankly, complications in traumatic ischemias are often so severe and common that if surgeons cannot solve the problem with current standard methods, then complications like delayed healing, chronic infection, or even amputation are sometimes just accepted as an expected, albeit unfortunate, outcome. The source candidly calls this the que sera sera attitude.
Whatever will be, will be. Just accepting bad outcomes.
Unfortunately, sometimes yes. The source identifies this que sera sera attitude itself as a significant dilemma, a kind of resignation to poor outcomes that potentially overlooks a viable adjunctive therapy like HBO that could change that outcome.
That's a powerful point. Acceptance becoming a barrier.
It can be. Ultimately, these dilemmas, accessibility, reimbursements, and attitudes, they're deeply interconnected. They can only really be solved by addressing all three simultaneously.
A systemic problem needs a systemic solution.
Exactly. Addressing these issues, in turn, has the potential to facilitate more supporting research by making it easier to actually study HBO in these acute populations. And most importantly, it could change those prevailing attitudes towards the utility and necessity of HBO in managing complex traumatic ischemias, making it a more integrated, accessible part of the trauma care system.
Okay, so big challenges, but potentially solvable with concerted effort. Now, given these challenges and the fact that perfect level 1 evidence doesn't exist for everything, how should clinicians make decisions? The source proposed a system.
Yes. Given the reality that, as the source notes, less than 20% of all decisions made in clinical medicine overall have robust, level 1 randomized controlled trial indications.
Only 20%. Wow.
Yeah, it suggests a more pragmatic system is often needed for making justifiable decisions regarding the use of therapies, including HBOs, in complex scenarios like traumatic ischemias where RCTs for every single nuance are impractical or maybe even non-existent.
Right. Need something practical.
Consequently, the source proposes using an effective-based indications, or EBI, evaluation system as a pragmatic tool for justifying the intervention, when the evidence, while maybe not universally level 1 across all conditions, is strongly supported by mechanism, lab data, and clinical experience.
Okay, effective-based indications, EBI. How does it work?
This proposed system, which is also referred to as rationale-based indications, or RBI, specifically in the context of justifying hyperbaric oxygen for crush injury and compartment syndrome in the source. It involves 5 assessments, as shown in Table 3.
Okay, 5 checks.
Each assessment evaluates a different aspect of the evidence and the rationale. Each is graded on a 2 best to 0 worst scale, and the points are summed up to generate a total score from 0 to 10.
Similar scoring to the Wellness score, 0-10. What's the threshold here?
Scores greater than 4 points are proposed within the system to provide justification for the intervention.
Okay, 4 means go. Can you walk us through Table 3 to see how it applies to crush injury and compartment syndrome using this rationale-based approach?
Absolutely.
Yeah.
Let's walk through Table 3 verbally. The 5 assessments and their scoring criteria are: 1. Treating physician's experiences. This assesses whether there is strong clinical experience supporting the intervention. That gets 2 points. Consistent experience, 1 point.
Yeah.
Or no support conflicting experience, 0 points. For both crush injury and compartment syndrome, this scores 1 point in the table, suggesting consistent clinical experience supports the intervention in both cases.
Okay, 1 point each for experience.
2. Mechanism of HBO and lab studies support the intervention. This assesses the strength of the scientific rationale and experimental data. Scores 2 points for strong evidence, like conclusive lab studies, clear mechanism, 1 point for consistent evidence, 0 points for no support conflicting evidence. Both crush injury, thinking about the edema cycle, oxygen diffusion, and compartment syndrome, recalling the Hargan's canine studies, score a full 2 points here, reflecting the strong physiological basis and supporting animal lab study data we discussed.
Okay, 2 points each for mechanism lab support. Strong science.
3. Publications and supporting literature. This looks at the published clinical reports. Scores 2 points for strong evidence, multiple consistent reports, maybe RCTs. 1 point if the evidence is generally consistent with supporting the intervention, like case series, single reports. 0 points if no support or conflicting evidence. Crush injury scores 1.5 points here. The table notes indicate using half points if the information falls between scoring criteria, so this likely reflects the combination of the RCTs plus the extensive case series literature. Compartment syndrome scores 1 point, reflecting the more limited but generally supportive clinical reports and case series available for it.
Okay, 1.5 for crush publications, 1 for SMCS publications.
4. No other treatments available. Failure and/or poor outcomes with current management. This assesses the clinical need, especially when standard therapies are insufficient or may be unavailable. Scores 2 points if no other effective treatments are available, or if standard treatments consistently yield poor outcomes in this situation. 1 point if evidence is consistent with supporting the intervention when standard therapy fails or is insufficient, 0 points otherwise. Crush injury scores 1 point here. Compartment syndrome scores a full 2 points here, specifically highlighting its potential role in that critical lag stage where conventional criteria for fasciotomy are not yet met, and there really is no other specific therapy available to interrupt the ongoing ischemia cycle at that point.
Ah, the what else can we do factor scores high for SMCS lag phase. Makes sense. 2 points there, 1 for crush.
5. Randomized control trials and/or head-to-head studies, 2 or more. This specifically scores the presence of the highest level of evidence. Scores 2 points if there are 2 or more such studies supporting the intervention, 1 point if there's maybe 1 study or limited RCT data, 0 points if RCTs show no benefit, there's no information, or possible harm. Crush injury scores 2 points here, thanks to the existence of those 2 relevant randomized controlled trials, Bouchard, Millar. Compartment syndrome scores 0 points as there are not 2 or more RCTs specifically confirming benefit for SMCS in the lag phase.
Okay, 2 points for crush RCTs, 0 for SMCS RCTs. So what are the total scores?
Summing these points gives us the score based on this proposed rationale-based evaluation. For crush injury, the total is 1 experience plus 2 mechanism lab plus 1.5 publications plus 1, no other TX needed, plus 2 RCTs equals 7.5 points.
7.5 for crush. High score.
Very high. For compartment syndrome, the total is 1 experience plus 2 mechanism lab plus 1 publications plus 2 no other TX plus 0 RCTs equals 6 points.
6 points for compartment syndrome, still well above the threshold.
Exactly. The source notes in Table 3 that scores greater than 4 points qualify the interventions as effective-based indications, EBI, within this proposed system. Both crush injury, with 7.5 points, and compartment syndrome, with 6 points, clearly meet this threshold using this system.
Okay.
Now, it's important to understand, as the notes in Table 3 emphasize, that this specific scoring system has yet to be validated as a formal clinical guideline. It's a proposal.
Right, it's a framework, not official yet.
Exactly. But it provides a structured, rationale-based approach for clinicians to help justify the use of HBOs in these specific conditions.
That's a really insightful system. I like how it provides a structured way to move beyond just asking, is there an RCT for this exact situation? And instead asks, is there a strong overall justification based on mechanism, all available evidence, and the clinical need? It acknowledges the realities of clinical research and complex trauma while still demanding a solid basis in evidence and rationale.
Well put. It aims for pragmatism grounded in science.
Okay, so for our final comprehensive recap then, wrapping up these important discussion points, we covered these significant dilemmas, accessibility, reimbursement, and attitudes that really limit the widespread use of HBO for acute traumatic ischemias in the U.S., despite the strong physiological rationale and compelling evidence showing significant complication reduction, particularly the RCTs and crush injury and burns.
Major barriers.
These are major systemic barriers that require a collective effort to address. Then we explore the rationale-based indications, or EB system, detailed in Table 3, as a proposed pragmatic tool for clinicians. It helps justify the use of HBOers for conditions like crush injury, which scored a high 7.5 points, and compartment syndrome, which scored 6 points, both well above the suggested threshold of 4. This system provides a structured framework for decision-making based on a multifaceted evaluation of evidence, mechanisms, and clinical need, offering a potential way forward even when level 1 evidence might be sparse for every specific scenario.
Excellent recap of the discussion. And just to restate the source material's own summary points, kind of bringing everything full circle now.
Yes. Let's hear the sources, bottom line.
Okay. Traumatic ischemias are a constellation of conditions with similar underlying pathophysiology. Crush injury serves as a useful prototype for understanding these conditions. The core components of this pathophysiology include the trauma itself, whether mechanical, thermal, or surgical, that critical self-perpetuating cycle of edema plus ischemia-hypoxia, and the inherent presence of a gradient of injury within the affected tissues. Traumatic ischemias progress through the 3 distinct stages of wound healing: inflammatory, repair, and remodeling, each with unique needs. Hyperbaric oxygen improves the environment for wound healing throughout these stages through its primary mechanism of hyperoxygenation via dissolved oxygen and other secondary mechanisms like vasoconstriction and support for host defenses. Oxygen needs and the specific benefits of HBO vary with the injury type and the specific stage of healing being targeted. Traumatic ischemias have predictable complications. Reports from studies show that outcomes in severe open fractures and burns are improved by a significant 20 to 30% when HBRO is used as an adjunct.
Key finding.
And finally, while challenges exist, like the availability of emergency-capable facilities and issues with reimbursements, HBO's inherent ability to directly address key components of the underlying pathophysiology suggests it should ideally be available to all major trauma centers managing these complex and challenging injuries.
It's a strong concluding statement from the source. So to bring our deep dive to a close now, we've really journeyed through the complex landscape of acute traumatic ischemias, haven't we? From the initial insult all the way through the long road of healing.
There's been a detailed exploration.
We've gained, I think, a much deeper understanding of the unifying pathophysiology, that vicious cycle of edema and ischemia, the critical gradient of injury, and explored the distinct stages of wound healing. Most importantly, we've seen how hyperbaric oxygen, through its unique mechanisms, offers a specific physiologically targeted intervention that can potentially make a real difference at each stage and in various specific conditions, from severe crush injuries and SMCS to burns, frostbite, threatened flaps, amputations, and reimplantations. We've examined the evidence, acknowledging its varying robustness, but noting that consistent signal of significant complication reduction in severe cases like crush injuries and burns, confirmed by randomized controlled trials,
Right.
and supported by strong mechanisms and clinical experience for other indications.
A fair summary of the evidence picture.
And this matters immensely to you, our listener, the specialist clinician, because these are some of the most challenging patients you will manage. Cases where conventional state-of-the-art care, as good as it is, still results in those unacceptably high complication rates.
The tough cases.
So understanding the rationale and the evidence for HBO, and having a framework like the RBI system to help justify its use, provides you with potential adjunctive strategies. Strategies to improve patient outcomes, reduce complications, potentially save limbs, and improve long-term function and quality of life.
And we've certainly highlighted the real-world challenges in integrating HPO into practice today, those significant issues of accessibility, reimbursement, and prevailing attitudes.
Yeah, the dilemmas are real.
There are significant hurdles that often prevent patients from accessing a therapy that could truly benefit them. But, understanding these barriers is the crucial first step towards advocating for better systems and greater access for the patients who stand to benefit the most from this physiologically sound intervention.
Exactly. Which leaves us with a final thought for you to consider as you process all this information we've discussed today.
Okay.
Given the strong physiological rationale, given the clear evidence showing significant complication reduction in severe cases like crush injuries and burns, given the compelling mechanistic data for conditions like compartment syndrome, and the potential benefits highlighted across the other traumatic ischemias, how can we, as clinicians, as researchers, as administrators, as a healthcare community, collectively work towards better integrating hyperbaric oxygen into the standard management pathways for acute traumatic ischemias? How do we ensure it's available when and where it can make the most difference for our patients?
That's the critical question moving forward.
It's a challenge, no doubt. It requires addressing systemic issues, requires changing attitudes, requires investment, but perhaps one absolutely worth tackling to improve outcomes for these incredibly complex and vulnerable patients.